For those that don't know, my name is Stuart Schlossman, and I want to thank you all for coming here today. MS Views and News was created years ago when I was diagnosed back in 1998. I couldn't find information. Fortunately, I was internet savvy. Fortunately, I was able to find the information that I needed, and then I started supplying it to others. We began supplying it, or I, and myself, began supplying it to a group of people in a support group down in Miami. That then led to support group leaders around the state finding out information that I was providing, and they asked me to send it to them as well, so that way they could provide it to their groups. Then people around the country started finding out about that and started asking for that information. The information that began with me just sending it to 5 people is now reaching people in 98 countries. Thank you. So, I'm happy about it, and I need to smile because I need to show you all that I could smile too. By the way, tonight's program is our 30th program of this year. 30th program, we have just one more to do. We have one more to do that will close out the 2013 season, and that will be in Melbourne, Florida, next Tuesday night. Also, this year was our first program that we did out of the state of Florida. We did a program in Atlanta, Georgia, just at the beginning of November. The people in Atlanta had never seen a program that we did. They're just used to like one-sided programs. So they were very happy to find that we were doing an A to Z type of program, beginning with MS 101, talking about all the different treatments that are out there, talking about symptom management and what they could do for this, talking about MS relapse, MRI, and many other things. We had an occupational therapist come in as well who discussed energy conservation for the holidays. After all, the holidays are coming up, so we thought that that was a good topic. The speakers loved the way that they were able to talk. The patients loved the way they were able to talk. The pharmaceutical companies want us to do more of these programs in other states. So we're going to be doing Florida, and we are now getting out to do other states as well. We hope to be in Alabama, Georgia, and the Carolinas during 2014, as well as Florida. So, before I begin, and before I go further, first let me thank Genzyme Sanofi for giving us the education grant to do tonight's program. Thank you. I would also like to thank Biogen, Infinity Clinical Research, Novartis, Questcor, and Teva, as well as all of our volunteers and those from our family that put up with me, and the doctors who have to put up with me and what I ask them to speak about. Okay? Tonight we're doing something different again. We have a person here who wanted to come to this program, who needed sign language interpretation, and we are providing that for this person here tonight. This is something new. We are, like I said, we're videotaping our programs. We're videotaping most of our programs right now, and this is allowing, again, for the people outside of Florida to see what we're providing. And it's becoming an enduring material, so that way, even if you get home from tonight's program and you don't remember half of it, because maybe you have cognitive problems, you can go to our YouTube channel, and you can just click on youtube.com/msviewsandnews and see the information and look at this program, as well as see previous programs that we have provided. We've had urologists, neurologists, occupational therapists, personal trainer, and other topics as well. And we hope that you can begin using this. In 2014, we've already got 2 programs on the books to start. If you ever go to our website, which is not up on the screen right now, because that's where we were having technical problems, you will go to our website and you can see the list of programs that are already underway and what we are getting for people to register to attend. In 2014, we hope to be doing at least 25 programs. Hopefully we'll get to 31 again as well. The people will enjoy having these programs. Tonight's program, I know you all want me to just get going here. There's an agenda on most of your tables. In fact, it's on all of your tables. Why do I know that? Because I put them there. So, there's 2 agendas on the table. You can see what the doctors are speaking about and for how long they'll be speaking. Dr. Steingo will be speaking first, thankfully. Thankfully, he's here. Thank you for making it here. Okay, Dr. Steingo will be speaking about diagnosing MS, what makes it so different, the early symptoms, treatment options, the second-generation MS medications. What does that mean? Emerging therapies. Okay, he'll speak about MS relapse, adherence, compliance, and reasons for switching. Wow. Big menu. Okay, great. And then after Dr. Steingo, we're going to have Dr. Samowicz. Dr. Samowicz is a urologist. He'll be speaking about the bladder issues. And then after Dr. Samowicz, we'll do a Q&A for both of them. We will have a microphone going around in the audience. We'll ask you guys to ask your questions on the microphone. These video cameras will not be taping you. They'll only hear your voices and your questions being asked. So without going any further, I want to thank you all for coming here tonight. And Dr. Steingo, you're up.
Okay, thank you, Stuart, and thank you all for coming. Some of these slides, many of you have seen before, so it will be revision. Some of you haven't seen slides, that will be education. So hopefully between revision and education, we get through quite a lot. Stuart told you about a lot of different topics we could talk about, and that's why I've done this for a couple of years, and you can see I've called it the land of MS. And there you can see the land of MS. So we could talk about each one of these topics all night. And Stuart ran off a bunch of topics that we could talk about. So our opportunities would be to say a few things or a little detail about a lot of topics, or to pick fewer topics and say more detail. So I'm going to try and balance that out a little bit and emphasize some items that I think are more important. Most times when I do this, Stuart tells me I have about 30 minutes, and then he tells me I'm going over. This time it's almost the opposite. He said to me, you have more time, so we can spend some more time on some of the favorite topics later on. But each one of these that you see over here could be a whole evening in itself. So that's where the feedback part is very important. When you get these sheets that Stuart asks you to fill in, it's very important that you tell us for future talks what you would need us to spend more time on. For example, do you want us to spend more time on talking about the diagnosis of MS? That might be for someone who's newly diagnosed or has an uncertain diagnosis. The diagnosis of MS is not always a clear-cut diagnosis. It's become much easier in the last 30 years since MRI scans came about, but there's no blood test. If you're diagnosed with MS, we can't take your blood. Doesn't tell us that you have MS. What the blood test tells us is that it rules out other diseases. Even the spinal fluid is not specific for MS. Some of the changes we see in the spinal fluid can be seen in similar and other autoimmune diseases, such as lupus and other autoimmune diseases. So the diagnosis of MS is won both by suspicion and by ruling out other diseases. It's very important. There have been a whole series of articles in the neurological journals this year about mislabeling of MS and about undiagnosing MS and about taking the diagnosis away when it's not made correctly. So these are always things we have to think about when we make the diagnosis, very important considerations. But the diagnosis is usually made by suspicion of the symptoms, by the MRI scans, and occasionally the spinal fluid. We don't often need the spinal fluid. You can see once we go past that stage of the diagnosis, we could spend all night talking about treatment aspects, treatment of the relapse, or treatment of the disease itself. We could talk about the symptom tower. Why do I call it the tower? In this land of MS, how many symptoms are there? There are many symptoms of MS. We could spend all night talking about symptoms of MS. We could talk about pain and fatigue and depression and bladder problems and on and on. That's why I call that the symptom tower, a tower of symptoms, the medical support. And the medical support, I'm talking about other aspects as well. The urologist, the ophthalmologist, the psychiatrist, all these people might be an important part of the team. And social support. What's a good example of social support? Right here, surrounding us, right? Yep. This kind of thing to me is good social support. You sit at a table, you meet somebody, sometimes you pick up a tip, sometimes you become friends, you learn about other meetings. So social support groups, the National MS Society groups, all those kind of things are very important social support. And then the most important group, which is why I put in block letters, is self-help. All the things you do for yourself. And really, if I was more artistic, I could probably do this in another way, because self-help really is the heart of the whole thing. If the self-help part doesn't come into play, then the rest of it all collapses. I'm going to populate this just like that. So this over here, the purpose of this now is to talk about a little bit about what is MS. And when you think about MS, you know, over the years we've always said MS, described by Charcot about 150 years ago, we've always said it is a demyelinating disease of the central nervous system. And we'll go over some of those terms in a minute. So the central nervous system means the brain and the spinal cord. as opposed to the nerves that run in your arms and legs that we call the peripheral nerves. So MS is a disease of the brain and the spinal cord. But the brain and the spinal cord are the targets of MS. MS is an autoimmune disease. The main problem really in MS is the immune system. Here, I can't really, I don't have a pointer. Shall I jump? The lymphocytes. Okay, so the main target, so in MS, something triggers off the immune system. That's why on the left-hand side, I put over here that there's a trigger that stimulates your immune system, activates the lymphocytes. Now, these lymphocytes have to cross a barrier, which is called the blood-brain barrier, and get in to attack the brain or the spinal cord. What are these triggers? What is this? A pointer? A pointer, there we go. Okay, thank you. Pointer arrived just in time for Christmas. So, triggers. Do we know about some triggers? We know about some triggers for MS. So the first thing that's important is genetic factors. So our kind of understanding is evolving now to say that if someone gets MS, they are probably genetically predisposed. So if there is a history of MS in your family, you have a higher risk of getting MS. The highest risk would be for an identical twin, but it would apply to parents and siblings and children that have a higher risk of getting MS. So we suspect that MS is in a genetically predisposed individual is then exposed to other factors that bring about their MS. And these other factors could be environmental factors, such as where you live, because MS is more common when you live in northern latitudes, up north. It could be infections. The one infection that definitely seems to have a link to stimulating MS is mono. So if you look at people with MS and look at their blood, you find antibodies to mono much more commonly than you do in people that don't have MS. So mono is definitely one trigger. But there are other triggers. And there's one very important trigger that we've become aware of in recent years, suspected for many years, but it's highly important. And there should not be a single person in this room who's not taking care of this particular trigger. What's that? There you go. Okay, vitamin D. And we know now that vitamin D is very important. At the recent European meeting in Copenhagen, every year there's a big European MS meeting in Copenhagen. It's a worldwide meeting. This past year in October, it was held in Copenhagen. There was actually a publication on somebody looking at vitamin D levels and MS progression and correlating progression with vitamin D level. And specifically, they said the higher the vitamin D level was, the lower the MS activity was. So if you look at your normal vitamin D range, the lab will quote a range of about 30 to 100. But for MS, we like the range to be about 75. So get your vitamin D checked. That's the only way I know how much for you to take. Check the vitamin D. That is an important environmental factor. Something in the diet. Let's see how this advances here. Okay, let's see if you can see it. It's been populated a little more, this slide. So you get these various environmental triggers, activate your immune system, which consists of lymphocytes called T cells and B cells. Both seem to be important in MS. In order to attack the brain, they have to pass this barrier called the blood-brain barrier and attack the central nervous system. Now, let's see if the next one works. There it is. You see the arrow flying across there? Did anybody see that arrow? Yes. Okay. So that summarizes what we've just said, what happens in MS. Something triggers off your... Oh, why is it not showing up there? There it is. So we have the triggers that we spoke about, activating the immune system, attacking the target. And the first thing that happens in MS is inflammation. So the very first thing that happens in MS is inflammation. The nervous system becomes inflamed by the attack of the immune system. And the inflammation attacks myelin, leading to loss of myelin, which is called demyelination. And the next stage is to attack the nerve cell called the axon. And if the nerve cell is attacked, it does not recover. So if myelin is attacked, myelin potentially could recover. But once the nerve cell is attacked, the nerve cell does not recover. That is a permanent injury. So what conclusions has that led us to? Which is the conclusions of all the studies that you read about. We want to start treatment early. You want to cut off the whole process early on. You don't want it to develop all the way down. If possible, you want to stop the treatment early on before you get a loss of the axon and before you get demyelination. This next slide over here shows you inflammation. So I'll point out what this is. Over here on the periphery, on the outside, this over here, and this, that's what normal brain tissue looks like. Normal brain tissue. Here's a blood vessel surrounded by millions of lymphocytes. So if you took a picture of the brain with inflammation in it, if you took this is what it would look like. This is what the inflammation would look like. Millions of lymphocytes surrounding a blood vessel. That's what inflammation would look like. That's what we would like to shut down. So now, once the whole process has started, you know, over the years, we've said that there are 4 types of MS. This is what they've classically said, that there are 4 types of MS. You're familiar, that's the 4 types over here. So the commonest type of MS is called relapsing and remitting MS, that most of you will know well. 85% of people or so, or 90%, start out with relapsing and remitting MS, which means they are subject to having episodes, or attacks, or exacerbations, or whatever name you want to give them. And we treat those early on. And then over a period of time, if we do not treat relapses and if we do not have any treatment, relapsing remitting MS can become progressive. That's called secondary progressive MS. So the whole goal of treatment in 2013 is to slow down the progression from relapsing remitting MS to secondary progressive MS. 20 years ago, before we had any treatments, there were several studies that were done, including a big Mayo Clinic study, and they said, what would happen if someone had relapsing remitting MS and we don't treat them? In fact, in 1990, there was no treatment, so it was easy to follow them. And what they found is that in 15 years, 50% of people had progressed. 15 years, 50% of people have progressed. Now think about this as a disease that typically starts in a younger age group, 20 to 40. That means by the time people are 30 to 50, 50% have progressed. Even more important, in 25 years, 80% of people have progressed. So even relapsing remitting MS without treatment, in 25 years, 80% of people have progressed. That's without treatment. And so the goal of our treatments is to stop that from happening. 10% of people have what we call primary progressive MS, where the MS will slowly progress from the onset, from the beginning, without any relapses. And a small number of these people with primary progressive MS might actually have a relapse out of the blue. That's called relapsing progressive MS. So that's what we've known all these years about the types of MS. But now we learn about earlier things. Now we can even diagnose MS earlier. So firstly, we had this condition called a clinically isolated syndrome. So what was that? In the past, in order to diagnose MS, we said someone has to have 2 episodes separated in space and time. It was important. With 1 episode, we could not make the diagnosis. There had to be 2 episodes. But now we know that sometimes, if someone has their first episode, we can look at their scan and we can say that there's a high likelihood that MS will develop. And we call that a clinically isolated syndrome after the first episode. If the scan is active, we might even be able to call it MS right from the beginning, but we treat clinically isolated syndrome exactly the same way. We essentially consider a clinically isolated syndrome to be early MS. And then we have this thing called a radiologically isolated syndrome. Now we're going even back earlier in time. And this is somebody that has a scan for some unrelated reason. They have no symptoms of MS. They have a head injury. They slipped and fell. Something hit them on the head, whatever reason it is. They have migraine. And we do a scan and say, wow, this looks like MS. And that's called a radiologically isolated syndrome, where the scan looks like MS, but there are no symptoms of MS. And they have done studies, several studies reported now with people with radiologically isolated syndrome. And some of these people do go on and develop definite MS. So radiologically isolated syndrome that most people do not actually treat, but that we follow closely, that may be the very earliest part of MS. So these are some of the types of MS. Now you could say, if someone has a relapse, is it important to treat a relapse? And this shows you over here. This is a disability scale that they did. I'll point to this over here. So the green bar over here is an increase in the disability by 1 point, and this turquoise, whatever it is a disability increase by 0.5 of a point. This is a disability scale. I'll give you some numbers as an example. A disability scale of 1 is someone you couldn't even measure their disability. A disability of 5.5 would be someone who's having trouble walking. You could notice it, but they don't need any device. A disability scale of 6 is someone who's using a cane. A disability of 6.5 is someone who's using a walker. So if someone has a relapse and they go from a 5.5 to a 6.5, they've gone from independent walking to using a walker with one relapse. So that's what can happen. What this study showed was that if you look at people 90 days, so let's point to the right-hand side. This is 90 days after people had a relapse, 90 days later, about 30% of people have a 1-point decline in their disability scale. And about 40% have more than a half a point decline in their disability scale. So that means 3 months after relapse, there is at least 30% chance of going down 1 point in the disability scale. Further emphasis, so I showed you before, we want to treat relapses early to shut down the inflammation so we don't progress to atrophy. And now I'm showing you another reason why we want to treat early, because we don't want the relapse to go on and to leave some permanent dysfunction. Now, when you're newly diagnosed, we're still in the early stages, talking about your newly diagnosed, is there some way we can predict what your outcome is going to be? We don't have a crystal ball, and there are constantly people that fool us, that come in with very mild symptoms and then progress, or that come in with a severe first episode and then do well. But there are some guidelines that we have. I don't know if is this coming through with the lights? It might not be easy to see this with all the lights around here. But basically what they looked at over here, this interesting study done by Scott, is they looked at 6 risk factors. The first one was the age at onset. And so what they said is that the younger the age of onset, that was a good factor. The older the age of onset generally tended to be less favorable for progression. And then they said, let's look at the symptoms at onset. So for example, some symptoms like optic neuritis, if you're going to choose symptoms, optic neuritis is a better symptom to choose than if the first episode was difficulty walking and loss of bladder control, as an example. Those would not be good first symptoms. So we could look at the age of onset, we could look at the symptoms at onset. We could look at the MRI scan. If the more that there was on the MRI scan also tended to suggest a more significant outcome and therefore more urgency to treat. And then the time between the first 2 attacks. The less the time, the worse the outcome was. And then how many attacks there were in the first 2 years. We were very happy if there were none, but if there are more attacks, this also tends to be more worrisome. And then how much did someone recover? Were they left with a lot of disability after the episode, or did they recover well? So these were 6 interesting things that you could look at and predict then what's the outcome likely to be in the long run and how urgently we should treat. 6 important points. And he looked at these over here, and you can see over here the risk. They're saying over here that if there's a low risk, if you only have 1 or 2 of the, this is the disability scale, and it's based on the number of these attacks over here, and clearly the more episodes you have, the worse the disability at the end of this period of follow-up. That's what this showed. So there's some risk factors that help us gauge how important treatment should be. And if I see someone who's reluctant to treat, and I see a lot of these factors, I'm going to show them this graph and say, this is why it's very important to treat. Now, how does the MRI scan help us? We're going to do a question and answer after, so if you could just write it down.
Okay, sure.
Unless there's something that's urgent. We'll do a question and answer at the end. So what this is showing you over here is looking at the MRI scan. Does the MRI scan help you predict what the outcome is going to be? So let's start off with someone that has optic neuritis, again, a very common early symptom. And we look at their MRI scan, and it shows no lesions and no white spots on the brain. Here we go, here's no lesions. What's the risk of developing MS? 20%. Let's say it showed 1 lesion, just 1. Now we're not talking about some random white spot that's non-specific. We're talking about a lesion in the brain, a white spot that looks like an MS spot. Let's say there's only 1 of them. What's the reason for what's the risk of developing MS? 80%. Even 1 spot gives you an 80% risk of MS. How about if you have 10 spots? What's your risk if it's 10 spots? 80%. So what's the point? If you've got no spots, your risk of MS is only 20%. If you've got any spots at all that are MS spots, your risk is the same. It's 80%. So what's the difference in the number of spots? The difference is in the eventual outcome. Look again at this disability scale over here on the right-hand side. The more spots there are, then at the end of a period of time when you evaluate the patients, the worse the outcome was. So the very presence of a spot tells you there's a risk for MS, and the more spots there are, tells you that there's likely to be more progression, and we need to be really active in the treatment. I'm going back to this disability scale again. Have a look at this line over here. This is a disability scale. I told you before that a 6 is a person that needs a cane. A 6.5 is someone that needs a walker. A 7 is someone that's in a wheelchair, maybe can stand and walk 2 steps, but they're in a wheelchair. An 8 is someone who essentially cannot walk at all. I want you to look at this number of 4 here. So this is people that have MS. How long did it take them to get to this number of 4? It took some people maybe 5 years to get there. It took some people 20 years to get to number 4. It took some people 25 years ago to get to number 4, disability scale of 4, and some people might be very lucky and never get there. We might call that benign MS. So what this is showing you is that this is how long people took to get to the disability level of 4. But I want you to look above this line, what happens. Once they get to a 4, you see these lines over here? They're parallel. They're all parallel lines. Once you get to a 4, doesn't matter how long it took you to get there. From 4 to 6 takes the same time. So whether it took you 5 years to get to 4, or 10 years to get to 4, or 20 years to get to 4, once you get to 4, 4 to 6 or 4 to 8 is exactly the same time. So what's the crucial message here? We need to stop you at 4. We need to put a gate at 4. We don't want you to get beyond 4. We want to try whatever we can to get you to stop you from getting to 4. We talked about some of this briefly before. We said that some people have benign MS. Benign MS means that when we look at someone, we cannot, really there's minimal disability. And how do we know that? We cannot predict that at the beginning. We don't have that crystal ball. We have some ideas by looking at your scans and all the other things we spoke about. But the way we classify benign MS is after you've had MS for about 10 years. And then we look at you and say you've had minimal disability, minimal attacks, you have benign MS. Does it mean you're free and clear? No. Sometimes people have been shown with benign MS that there still may be some progression. So we still always need to be vigilant and alert. Most people have the types of MS we've talked about. We spoke about the progression of 15 and 25 years. There is this very unfortunate and infrequent group. About 5% of people have what we call malignant MS. There's different names of this, but malignant MS means just rapid progression. And even now, these are people who attempt not to respond to any of our therapies. We go through all the usual therapies. We have 10 FDA approved drugs as of today, maybe another one soon, but we have, with all the medications and chemotherapy, people may not respond sometimes. That is what we call malignant MS. This, to me, is an amazing, actually the most amazing slide of all night. Because remember, until 1993, May 1993, was the first day that we had a drug for MS that was officially approved. That was beta-seron, May 1993. Prior to that, what would the screen have looked like? A big blue empty screen, nothing. So now we have 10 FDA approved drugs, which are shown over here. All these over here with this color scheme, which shows up here as a pale kind of something. There are about 10 of these that are approved. Then you have Campath. Campath is a drug which the FDA is currently evaluating. Potentially will be approved later in the month. And then on the right-hand side, I've included some of the drugs that are in research. We'll mention some of them in a minute. So remember, as of today, 10 approved drugs for MS. Some experimental stuff, some drugs that are coming, some exciting and new stuff. We have already 10. In the next maybe half a dozen years, we could have 15 drugs approved for MS. So if you see someone, it's going to be very important to maybe personalize the medication. We're hoping for more and more of that. You're going to hear us talk more and more about personalized medicine, finding the right kind of medication that's best for you. So let's look at some of these over here. On the left-hand side is siponimod and ponesimod. You see how their names end MOD and MOD? So they are related to fingolimod, Gilenya. So there are new medications being developed that work very similarly to Gilenya. And then there's a vaccine that's being developed. It's called a T-cell vaccine. T-cell is the name. It used to have a different name. Some of you, if anybody ever had that, it was called Tovaxo. Now it's called T-Selna. And then there's a medication that potentially for some progressive types of MS called masitinib. And then there's studies ongoing with vitamin D and statins and tetracycline and minocycline, other substances, common substances that work on the immune system that may have some effect on MS. So these are experimental medications even further ahead. On the previous page I showed you over here, these three, daclizumab, ofatumumab, can you see these names? They're interesting names to pronounce. We're going to have to learn how to say all these things, right? Daclizumab, ofatumumab, or ocrelizumab. Hey, you know, they're tongue twisters. And then they give them a name, and they give them names like Gelenia, Tecfidera, Aubagio, Tysabri. We can't pronounce those either, but we learn. We've got to learn the language. So there's a lot of stuff coming with the medications. You know what, my early theme was that we should treat people with MS. When someone is diagnosed with MS, we don't know what the outcome is going to be. We have some predictive factors, but we don't know. And so we say treat them early. And so all of the trials have shown that if you have patients with clinically isolated syndrome, early on, treat them early, because if you treat them early, it delays the progression of their disease. And in some instances, it may delay the development of physical disability. So that's why we need to treat people early. And what are the goals of our treatment? It's all these things that we want to do. We want to reduce the frequency of the relapses. And most importantly, we want to slow down the progression of disability. We want to reduce the MRI activity. That's one of our measures. So these first three things that you looked at over here, relapses, disability, and MRI scans are our measures in all the clinical trials. All the trials for all the drugs, all 10 of them that were approved, the ones that are coming, every one of them, the FDA says, how do you know that this drug is going to work? They say to the pharmaceutical company, we need some end points. We need to know some way this drug is going to work. What are we going to measure? And so these are the things we measure. Relapses, disability, and what's the outcome on the MRI scans? Has there been some favorable activity? And of course, we're trying to prevent any other problems, morbidity from the symptoms. We want to make sure you take the medication and that it's as safe as possible in the long term. And so is it easy to make a decision what you should take? Is it simply a question of somebody saying to me, well, I don't know these drugs. Somebody said that to me today. I don't know these medications. Just tell me what I should take. I said, I'm not going to do that anymore. I said, when we had 1 or 2 drugs, we could sit and talk about them. But we have 10 drugs now. We've got to talk about all kinds of things. And this slide kind of highlights it for you a little bit about all the different issues that could be involved in making a decision. That I have to be thinking about, that you have to be thinking about all the time. Things to think about. Are we going to think about safety? Efficacy. Does the medication work? How effective is it? Am I going to tolerate it? How convenient is it? How do you monitor it? What do you have to do? Are there pregnancy issues? What do I prefer? What does the patient prefer? What evidence is there? What's my experience? What's your experience? What's the mechanism of action? Does that make a difference? That might predict some of the side effects. What's the cost? All big things. I think some of the biggest common ones are safety, efficacy, and tolerability. Cost and convenience are all big things, but they're all big. Pregnancy issues, if you're in that age, which is common for MS patients. So these are all things that are very important things for us to think about and try and assimilate as quickly as we can. Here's the most important thing, is when someone is newly diagnosed, is to establish realistic expectations. For example, someone said to me today when we were talking about a disease-modifying drug, what is the effect of the disease-modifying drug on their symptoms? Am I going to walk better? Am I going to have less fatigue? And I said, no. That's different. That's in the symptom tower. That's dealing with your symptoms. That's what we're going to deal with next time. Today, our purpose is to talk about the disease-modifying drug that is going to slow down your progression of your disease, stop you from having relapses, and improve your MRI outcomes. And therefore, you might feel better, but symptom management is going to be a whole different discussion that we're going to work at some point. And so here's some, you might think these things at the bottom. Look at these last 4 checked off points here. That these drugs only work if patients take them. Does that sound corny? But how often does it happen? And someone comes in and says, I'm not feeling good. Well, I'm saying, okay, your medication X is not working. Well, I haven't been taking it for the last 3 months. And there's a variety of reasons. It could be insurance. But all the companies have financial assistance programs. You need to call. You need to have good communication with your healthcare providers. So if there's an insurance issue, we can discuss it. And then the other realistic points, we spoke about this. These drugs don't cure MS. So we don't have anything realistic about the cure. We're trying to change the course of the disease. This shows you the adherence to injectable medications. So this was done in Canada. This was a study in Ottawa. And you might say, well, that's obvious. People took injections. And look at this over here. This is where in Canada it's a captive audience, as we might be one of these years very soon. And so they know exactly what people are taking. They know everything about you. Just like very soon with our new insurance things, everybody can know everything about you. Where you were born, what you eat, what you had for breakfast, everything. So in Canada, they know everything that everybody got, every drug. Did they take it? Did they comply? Did they ask for new? And look at the drop. The drop-off rate in 2 years, about 50% of patients on injectables were not complying anymore, not taking them. So a high drop-off rate. And that's why hopefully we'll see better adherence with oral medications. And there's some specific reasons why people with MS don't take their drugs. Here's a summary of some of the reasons. People might be needle-phobic. That's not an excuse anymore. We've got 3 oral medications. People might have adverse effects. They might have side effects. Well, we need to know about those because we can manage many of the side effects. And then they might say the drug's not working. And so I say, how do you know it's not working? Well, I don't feel any better. Remember, the expectations. The purpose of this drug is to stop you from getting worse. I have to do something else to make you feel better, whatever the problem might be. Is it fatigue? Is it depression? Is it pain? Is it bladder problems? I need to work on the symptoms to try and make you feel better. And then depression. And it's been clearly shown that firstly, in people with MS, there is a higher risk of depression. And secondly, people that are depressed take their medications less often. I'll just briefly look at this one over here. This essentially says that it's very important to have good communication about everything, about taking your medication, about the side effects, screening, all these things. Communication is very important. That's, in the interest of time, let's move to this one over here, which is what I was saying, is that going forward, what we're trying to establish is what we call personalized medicine or individualized treatment, taking a given individual and saying, what's best for you? And let's look at all these things that we have to look at. What's involved in the monitoring for this drug? What do we have to do? Do you have to see an ophthalmologist? Do you have to have an EKG? Do you have to have some blood work? Do you have to get a TB test? How do we monitor and how do we screen you? Going forward, how difficult is it? What do we have to do regularly every month to check and see how you're doing? What about the cost? So now we're seeing more and more insurance companies coming down on us with that and having to have more and more fights about saying this drug is step 1 and this one is step 2 and this one is step 3. And so we've got to put on the boxing gloves and fight them sometimes. And then the risks and the benefits. Everything you've got to look at with that. Everything you do, what's the risk and what's the benefit? Everything you do in life is like that, isn't it? What's the risk of coming here tonight? You could get food poisoning. But that's never happened. So what's the benefit? So what's the benefit? And by the way, I could not put cartoons in the show tonight. I could not put any cartoons because they're videotaping me in cartoons. I'm told if I put a cartoon in, then Tribune or some newspaper is going to sue me for like $10 million. So I had to take out all the cartoons. I have to try and make some jokes. But okay, these are all the things that you have to look at over here. What's the efficacy? Is the same thing again. These are all the points I want you to remember. And these points are important in a variety of situations. They're important firstly when you start a medication. So when you start a medication, you've got to think about all those things in that slide, but they're going to be important in other situations. How about when the medication's not working and now you want to switch? It becomes important to look at those exact same points again. Exact same points. I'll put them up one more time. Monitoring, screening, cost and convenience, risks and benefits, efficacy, safety and tolerability. Always thinking about those things. There's some other things you might have to think about. All these things. What's your general health like? Do you have any other conditions? For example, are you depressed? Do you have diabetes? How bad is the disease? Your family history, your risk tolerance, childbearing potential, JC virus antibody status, a variety of different things, financial concerns, many things. And here's some, just a list. This list goes on and on. These are all things we have to know about. So in our office, so those of you who come to my office know that when you come in, every time we hand you a sheet of paper, and it says on that sheet of paper, write down on this paper all your medications. And on page 2 it says write down all your other conditions. and it says write down your questions. And these are crucial things to make your visit worthwhile. You've got to write those things down, and to me it's frustrating when someone, and it's common that someone writes the same. And I guarantee you, if I could collect something every time someone said the same, I could probably, get a meal. But I mean, it's very important to write everything down because we need to look at interactions. What are the interactions between your drugs and new drugs? Because oftentimes, guess what? When I plug in the medication someone's on, there's 2 medications that someone else gave them that are interacting that they need to know about. They say these 2 drugs together might cause kidney problems or something like that. So it's very important that you write down a list of your medications and your questions, because in 1 second that dictates the visit. If you write down your question, chief complaint, none, then we're all happy. But chief complaint, I have urinary frequency and I have frequent infections. Now I know where our discussion may lead, or I have fatigue or whatever. It's very important to write everything down, and that's why we need to know about all these conditions that you have. They may play a part in the drug that we choose. So we need to start you on a medication, and we need to switch you when your medication is not doing well. And how do we know when your medication is not doing well? What are the 3 things that I've been talking about? Again, the same message that I want to emphasize. We look at the same 3 measurements: relapses, disability progression, and your MRI scan. We can use the same measures again. Look how important those are. In all aspects, they surround us. So we look at those and say, how are you doing? Are you having relapses? Are you progressing? Is your MRI scan worse? Does it have activity on it? 3 very important things. But we look at some other things. There may be some other reasons why you need to get off a medication. Is it safe for you? Is it tolerable? Can you tolerate it? What's the cost and what's the convenience, and is it on your insurance company's formulary? So those are all things we want to look at. That summarizes them over there. And this says over here some important things, some important points over here. Is it important to choose a drug based on its mechanism of action? So I showed you before 10 drugs that are approved, and there are many drugs there that have different mechanisms of action. Interferons are one category, but they work differently from Copaxone, which works differently from Gilenya, which works differently from Tecfidera, which is different to Aubagio. They all have different mechanisms. So if one drug fails, you should not ask me the question, how effective is this drug? Does it have a different mechanism of action? Because if the other mechanism failed you, a new mechanism might work better for you. And there are lifestyle considerations too. We talked about all the diseases you could have, but lifestyle considerations. What's the side effects? Childbearing potential. Are you in a pregnancy age group? Employment, finances, things like that are all very important. And here's some of the monitoring. We can briefly talk about some of the monitoring over here. All the things that you might need to do depending on your drug. We might need to look at the liver, at the thyroid. You might need to do some eye testing, blood cell counts, check your lungs, blood pressure testing. There's a lot of things that might be required, and we need to know about these and emphasize these. And here's safety and tolerability, some of the things that can happen with some of these medications. We never claim these medications are free of side effects, because that doesn't exist. But let's know about them. But the reassuring thing to me is that I want you to know about these always, because if you have a symptom that starts, you should call your physician right away. You don't wait. And nor should you assume it's something else. So flu-like symptoms, depression, check the liver, check the blood count, lipoatrophy, atrophy of the skin from repeated injections, suppression of the immune system leading to risk of infections, malignancies. Could that happen down the road? New medications down the road? Let's be vigilant about that. Slowing of the heart rate, macular edema, swelling of the macula in the eye, liver and lung problems. How are we doing for time? I set my...
You've got time.
Like
Get another 10 minutes.
10 minutes? Wow. All right. This, I'm just going to look at this briefly. Basically, you all know about the symptoms of MS, so we won't belabor this one over here. There's many symptoms, and that all, if you're interested one day, tell Stuart if you want to do, we could do a whole session on just symptom management. We could consider that sometime. The reason I put this very important slide up over here is to show you some of the drugs that are used to treat MS, the importance of us knowing all your medications. Do you think there's potential for interaction when you're taking something for fatigue, and something for depression, and something for spasticity, and something for your bladder, and something for constipation, and something for dizziness, and something for cognitive function, and something for tremor? You get the message. How much opportunity is there? And then on top of that, wait a second, you're diabetic, or you have some other thing. You have blood hypertension. I mean, you have some other condition. How many medications could you be on? We need to be aware all the time of interactions. That's what the point of that slide is. Let's be aware of interactions. I won't talk too much about polypharmacy. Means taking many different drugs, and we just need to pay attention to the interaction of all these different medications. So I'll go now to this last section over here, seeing I have 9 minutes to go, on self-help, and make some points about self-help. I've done many different acronyms over time. This is my old acronym. It was called Fresh Minds. So those who've been coming to this for a few years, I used to have Fresh Minds. Then one day I was sitting at an MS meeting somewhere, and I was bored, and I've got a new acronym. That's what I do at meetings. I make acronyms. And I don't know what happened to the temperature thing there. Maybe that was too late at night when I did this. But so this is my new acronym for what you need to do for yourself. So that's what I would say. Always ask, what can I do for myself? Is that selfish? What can I do for myself? No, you're taking care of yourself. So T, temperature. E, what are your expectations? We've spoken about that, your expectations. How important it is to understand what the medication is going to do and when you need to call and speak to one of your healthcare providers. Adherence, taking your medication, complying with it. And then mental aspects. Memory, mental stimulation, keeping your mind engaged. Your outlook, having a positive outlook. And this is part of it, coming to groups, support groups, MS Society groups, groups like this. Very important. Doing things online. Managing fatigue, knowing how to manage fatigue. Food, relationships, personal relationships, family, friends, groups, interactions, exercise, news, keeping up with the news, MS views and news. I put this as a separate one. Vitamin, probably I was running out of something else here. I needed a D. I could have kept it with food. But vitamin D is so important that is why I put vitamin D on its own. And then finally, smoking. And it's become more and more evident over time that smoking is another major risk factor for MS. And now I can tell you in the last few months of this year, I could put S as another I could use another S over here for this whole program of self-help. Anybody else know what the other S is?
Support.
Support we kind of got. We got support. All these things are support. It's in the diet. I'll give you a clue that it's in the diet. Salt. Did somebody say salt? Was that you? Yeah. You're not allowed to answer. That would be like me winning the raffle. Did you tell everybody that I won the raffle already? Yeah. Salt. So in the last few months, there have been studies in the last year on salt intake and MS. So you all know that salt is bad it causes hypertension and things like that. But salt, table salt that you put in your food there, I hope you didn't, but that's salt. Salt for MS, they have shown that high salt intake correlates with progression of MS. Just like low vitamin D correlates with progression of MS, high salt intake. So you need to reduce your salt. So don't add salt. Number one, don't add it. Number two, eat low salt foods. Have a look what you're eating. Have a look at your food. If you like snacks and if you cook, keep the salt away. These are some interesting studies that are coming up. Salt. Exercise. And this means both physical and mental. And again, in recent months, I quoted you before on the Copenhagen MS meeting and other meetings that have shown how important exercise is. And people often say, I can't exercise. I'm too fatigued. So I said, did you try it? I said, I tried. I said, how long did you exercise for? I said, half an hour. I said, if you exercise for half an hour and you were too fatigued, what should you do next? And the answer I usually get is stop exercising. I say, no, how about trying just 10 minutes? Just reduce your time. It's very important to exercise. And someone says, I can't walk. Okay, how many chair exercises are there? And you go on the internet and search chair exercises, wheelchair exercises. There are all kinds of exercises that you can do. If your legs are weak, work on your arms. There's all kinds of exercises. And physical exercise is not only important physically, it's also important mentally. They've shown that people that do physical exercise also do better with their memory. And then there's mental exercise, of course, and there's many different things you can do. You can go on the internet, you can do crossword puzzles, you can do Sudoku, you can sign up with Lumosity. There's all kinds of things that you can do that are very important. But for exercise to succeed, you need to do these things. It's never going to work if you're not motivated, and it's not easy for you to do and available and affordable and convenient and enjoyable. And how do you achieve these things? Well, you need some motivation yourself. I always like someone to start off with a physical therapist, and hopefully I've got the right therapist who is going to be an educator and a motivator and make you motivated. So when you're finished with your physical therapy, you now go home with a sheet of exercises that you want to do on a regular basis. So that's very important. And the standard exercises that I always recommend are these. Some people can do them, some may not. Balance may not be a factor if you can't walk or don't walk well. Balance, exercise, stretching, and strengthening always is my program to talk about with exercise. And I think I'll end off over here kind of on talking a little bit more about the nutritional part of it. I think nutrition is important. Some people think it's more important than other people. More and more we're learning about the importance of nutrition. I just gave you the example a little while ago about talking about salt. So it's new. I haven't even incorporated it into this set of slides over here, but that will come into this set of slides. And so we know about salt, we know about vitamin D, and we're learning other things as time goes on. And this is what I put up here. It's called defensive nutrition. You could call this what my grandmother told me, or my grandfather. And it says, eat breakfast. You know, breakfast is important. Don't skip meals. Don't skip meals. Rather, don't go for the highs and the lows. Don't skip meals. Rather have more small meals than skipping meals and have big meals. And talking a little bit about the importance of fat and fiber, we know we should avoid saturated fats. Look at your diet. Look at what you eat. Try and avoid eating saturated fats. Eat more fiber. Where does all this come from? Plants and vegetables. A plant and vegetable based diet. Keep adequate amounts of fluids. Drink adequate amounts of fluids. And then take supplements, but don't overtake supplements. Don't take things that you're not sure about. Don't take things you're not sure about. Don't take too many of them. We know there's some supplements that are not good for MS and not good for anybody because they're unknown, they're unproven. Don't take anything that says supports or stimulates your immune system. You have an immune system that's already overactive. It's just attacking your nervous system in this situation, but you want to avoid things that stimulate the immune system. This is what I call defensive dining. So if I said to you, you could eat healthy stuff, you still need to have control over what you eat. You need to have calorie control. So you could still be a vegetarian and eat too much vegetables and eat cheese and eat too much cheese if you're vegetarian. Share portions. So who do you share the portions with? Who am I referring to sharing with? Yourself. That's what I'm referring to. Start with sharing with yourself. So the first thing is go to a restaurant and order a portion of pasta. And they bring you enough for a family of 4. Yeah. Share it with yourself. That's what I say. At the beginning of the meal, ask them to bring you a box and say, I want to, and pack half of it away right away. Right away, pack half of it in the box to take home for another meal. So you've already reduced the price of your meal by 50%. Now what's left on your plate, spread it out. It's going to fill the plate. And you've got enough to eat. I guarantee if you do it and you eat slowly, you won't be hungry. Put the salad dressing on the side. Order, low-fat salad dressings. Alcohol's got a lot of calories. And then salt we spoke about, and sugar you all know is a poison. And the plants. A lot of this stuff that I got over here that I already found good was from Joel Furman. If you haven't watched Joel Furman's specials on PBS, they're really interesting. Joel Furman on PBS, really I like to watch his specials. And he talks about eating, the colored vegetables, onions, mushrooms, berries, seeds, spinach, kale, avocado, all very important to eat. Again, talking about vitamin D, because I don't think you can ever hear enough about vitamin D. There are vitamin D receptors that are widespread in your body. We've always talked about vitamin D in bones. But now what we know is the importance of vitamin D in MS. And vitamin D appears to be you've heard the word oxidants and antioxidants. Everybody says buy this and, have vitamin C, it's an antioxidant. Go to some store and get this latest antioxidant. Go and get this antioxidant. Antioxidants all over the place. Buy some antioxidants. Well, vitamin D on the surface of the cell is a receptor on the cell surface that promotes the entry of antioxidants. And we estimate that although the level should be 30 to 100, the level for vitamin D we're kind of aiming for is about 75. You don't want to take doses that are too high. Okay? He's okay? Nutrition, more stuff. A vegetable and fruit-based diet. We talked about vitamin D. Vitamin B12 is very important for the nervous system in general, for the nervous system health for everybody. So if you have a disease of the nervous system, B12 is important. The unsaturated fatty acids to replace the fatty acids you're not eating. Fiber, calorie control. I put at the bottom over here some of the references if anybody wants to read these. You all know about, or most of you know about the Swank diet. But there's a book called The Blue Zone that is very good. And the other book that I think that if you want to read a diet that is very interesting is the China Study. So the China Study, if anybody wants to do that. Anybody reading the China Study? You're reading it or you read it? Good. Excellent. Here's what I talked about. Here's the plate. Are the two dark circles the same? You know they obviously are. It's an illusion. They look identical, the same diameter. But if you eat something on a large plate like that, you think you're getting less. Oh, well, I've got hardly any food on this plate. There's no food. Look how much you got. Your plate's full, but I've got nothing. So there could be an illusion. So I say take half of your pasta. Now, what I said before about the restaurant was take half of the pasta out. Go to Olive Garden, take half of the pasta out, and you've got another meal. However, if you go to an expensive restaurant, that is true. The more you pay, the less you get. So if you want to eat less, pay more. Right? Here's another optical illusion I thought was interesting. Look at the boxes over here. So if I tell you this box over here has got more popcorn than that box, you're going to say, sure it has. It's 3 times the height. But over here, it's not as easy to tell. That's because over here there's only one dimension that's larger, whereas here it's larger in 2 dimensions. So this one over here has got much more than that one, but you can't tell as you can over there. So they can trick you in many ways. Stuart, yes? That's, one? All right. This is the. I'm not going to go over these very much. Let me just make this last point over here about fatigue with MS. This is the last set. Fatigue about MS is very, very important to think about it. If you go to your physician and say, I've got fatigue, that doesn't mean you say, I've got fatigue, and I'm going to write you a script so I can get out of there and go and watch the basketball tonight. It's not quite as easy. Fatigue, there are 2 types of fatigue in MS. There is what we call primary MS fatigue. That's the type that nobody understands. Nobody wants to understand. Insurance companies don't want to understand that you can take Provigil for primary MS fatigue. They say, what's that? Because you can't measure it. But we should never lose sight of the fact that there could be secondary MS fatigue, that you could be fatigued for other reasons. Why? Because your muscles are weak and you're deconditioned and you've got no endurance, or you're not sleeping well, or you're depressed, or you get bladder problems and wake up 17 times at night, or you're heat sensitive, or you've got medication side effects or other medical conditions. So always think about when you've got fatigue, other than the MS fatigue that I might have, could there be something else contributing that we might be able to treat? Do some exercise, build up your endurance, take care of your bladder so you don't wake up at night. Let's take care of all the other matters. So on that note, I am sorry that I fatigued all of you. Thank you for your attention. That's 50 minutes.
Thank you, Dr. Steingo.
Thank you.
So next, we're going to ask Dr. Harvey Samowitz to come up. All right, so Dr. Samowicz is going to introduce himself and all that he does, and he's got a couple of offices around. If anybody needs a new urologist, I recommend him, but I've never seen him, so take it at face value. Thank you.
Oh, thank you. First of all, I want to thank Dr. Steingo very much. I really enjoy his talks. I get a lot out of it. Just to give you a little background, my specialty is in voiding dysfunction. I just got recently board certified in female pelvic medicine and reconstructive surgery. And That's in addition to my general urology board certification. And the reason is because when I finished my general urology residency, we didn't have enough on neurourology. We didn't get enough information, enough training on how to manage difficult neurological cases and as well as female urology, urogynecology. So I did a fellowship in that, and they just now established this new board. And so I just passed my exam. And, but as a result, in our group, I handle a lot of the patients that have the unusual voiding problems, the neurological problems, and the female pelvic issues, and so on. I have 5 partners, and we have offices in Aventura and Pembroke Pines. We have another office in Miami Lakes, but I found that the travel was a little bit much. So I limit myself to just 2 offices. Okay, so I'm going to talk about the urological implications of MS. A lot of the issues that MS patients have with their bladder, you'll also find in the general population as well. So a lot of this does apply to other patients because urinary symptoms are very common, and I'll get to that. But I'm just going to very quickly go over some of these issues, and this is just the introduction. One of the things that many people don't realize is that the urinary system is sometimes the canary in the coal mine for MS patients. Sometimes it's the first symptom that they'll have for their problem. And so 10% of patients will initially present with acute urinary symptoms, and at that time it may not be diagnosed. 2% of initial cases, the urinary symptoms are the only presenting symptom. Up to 80% of MS patients complain of voiding symptoms at some time. And it is a significant problem because in 5 to 55% of MS patients, there can be morbidity associated, significant morbidity and mortality from their problem, from their urological problems. Last week was the National Bladder Health Week, and I like this poster very much because it highlights some of the significance of urological issues for the general population as well as the MS population. So 25 million Americans have incontinence. 33 million Americans have overactive bladder. And I'll go into the definition of that a little bit later, but most of you probably have seen the advertisements on television and in the print magazines on what overactive bladder is. And you probably can imagine that's more severe and more common in the MS group. 50% of men will have urinary incontinence after radical prostatectomy, and it's 4 million visits for urinary tract 4 million doctor visits for urinary tract infection. So overactive bladder is a significant problem not only for the MS patient but in the general population. But overactive bladder affects 33 million Americans. It does increase frequency with age. It's more common in women than in men. And it's associated with other morbidities, such as high blood pressure, heart disease, and allergies. Obesity and diabetes also are comorbidities and a greater association for overactive bladder. I'm sure this is sort of very obvious to many of you, but I just thought I'd just highlight what the anatomy is that we're going to be talking about. So, obviously we have our kidneys. This sort of suggests that the kidneys are lower down than they really are. The kidneys are actually protected by the rib cage. You can't palpate the kidneys, but your doctor may see if your kidneys are tender by kind of pounding on your back a little bit, and what he's doing, he's rattling the cage to see if the kidneys are tender. So this is sort of deceiving that the kidneys are down low. People say, oh, my kidneys are killing me, and they're pointing to their lower back. It's really much higher. You can't even reach up that high, truthfully. The kidneys then drain the urine through the ureters. These are spaghetti-sized tubes that then go to the bladder. And the bladder consists of a muscle called detrusor. The detrusor muscle is this interlacing muscle that is responsible for contraction and pushing the urine out. It's a very elastic muscle, and it has to be able to expand as well as contract. The urinary sphincter is the valve that keeps the urine in. It is basically closed all the time except when you want to void and empty, and that's when the urinary sphincter has to relax. The urethra is the tube that carries the urine out from the bladder to the outside, and at the very end is the meatus. The meatus is the external opening that is in the vagina in females and at the tip of the penis in men. So, quite simply, the bladder has only two jobs. It has to store urine and it has to be able to empty urine. In the storage phase, the bladder muscle has to relax and the urinary sphincter contracts to hold the urine in. During the emptying phase, the bladder muscle contracts, pushing the urine out, but then the opening, the sphincter has to relax to be able to allow for complete emptying. What sometimes happens is the two don't work correctly together, and that's called dyssynergia. And that's something important that we'll talk about in a moment. So the bladder function problems, we kind of divide them simply into storage problems, emptying problems, and then there's the combination. The bladder is a very complex organ in the sense that it has its own nervous system, and then it has, from above, superimposed onto itself, other nervous systems. So part of it is coming from the base of the brain, the spinal cord, and at the base of the spine is the spinal micturition center, which also is very important in the coordination of the bladder and the sphincter and so on. So it really, and then in the pelvis, there's the sacral roots and the pelvic nerves that are all very important in the functioning of the bladder and the sphincter. So there's all different variations of urological problems that can happen with MS patients depending on where their lesions are, depending on where their problem is. So avoiding dysfunction in MS, there's quite a number here. I'm going to go through these one by one. The first one is detrusor hyperreflexia versus overactive bladder. When I was in training, they made the distinction that if a bladder that was overactive had a neurological basis to it, if you could define a neurological reason, MS, Parkinson's, spinal cord injury, if you could find a reason why the bladder was overactive, it was called detrusor hyperreflexia. If it was idiopathic and you didn't understand why their bladder acted the way it does, then it was overactive bladder. When you see the ads on television and so on, they talk about overactive bladder because the general population, and most of the time, it's idiopathic. It's unclear. We don't know why most people have this problem. But in a MS patient, we refer to it as detrusor hyperreflexia. Why can't you hear a pterodactyl going to the bathroom? Because the P is silent. Detrusor hyperreflexia is the frequency urgency. It's where the bladder doesn't want to store very well. It will contract at a low volume. The bladder, as I said, has sort of its own nervous system built into it. And if it gets, quote unquote, nervous, it'll want to push the urine out. And sometimes the patient's on their way to the bathroom and they haven't had a chance to get there yet and it's already pushing the urine out. That's referred to as urge incontinence, where there's sort of sometimes a warning that the patient will need to use the bathroom and the urine will just get pushed out. Other types of incontinence, which are sometimes found in MS patients, are stress incontinence. Stress incontinence doesn't mean that you've had a bad day. Stress incontinence means that the sphincter itself is not well supported, it's not competent, the valve is broken, and the urine leaks out, typically with coughing, sneezing, laughing, lifting, straining, bending down, lifting, jumping, running, those sort of activities where the sphincter either drops down in a female and lets go, or in a male, because they've maybe had surgery and their sphincter is not strong, then the urine will leak out. But it's usually found in females because they don't have the support of the urethra, and that's stress incontinence. Another type of incontinence would be overflow incontinence, where the bladder is at its maximum capacity and it just overflows. The pressure builds up just simply from volume, and the patient just leaks out. Another type of incontinence is functional incontinence, which can sometimes be found in MS patients, where because of physical limitations and they can't get to the bathroom or to a commode or to a urinal quickly enough, they will leak just because of the time it takes and to get to that ability to empty. And then, of course, there's mixed incontinence, which is a combination of any of the above. So another problem that can happen with the MS patients is bladder areflexia. And bladder areflexia means where the bladder has lost its muscle tone. It's lost its ability to contract well, and it becomes sort of a floppy sac. The detrusor, which is the bladder muscle, is not able to function properly and push the urine out. These patients sometimes will just have urinary retention, and if they get to the point where the bladder's reached its maximum capacity, it's overflow incontinence and they just leak. Detrusor sphincter dyssynergia is that complex situation where the bladder and the sphincter don't talk to each other very well. And unfortunately, this is not uncommon in the MS population. It's where the bladder wants to contract to push the urine out, but the sphincter has not relaxed to allow it to completely open and let the urine out easily. And what happens is the bladder then has to work against this partially closed outlet, and it's not going to be able to empty completely. Over time, the bladder will lose its ability to contract, or it will become even more nervous, similar to when men have enlarged prostates and their bladders get overactive from an enlarged prostate. It's because there's a partial obstruction for them. So this dyssynergia, this lack of coordination between the sphincter and the bladder, is something that's sort of characteristic in MS patients, and it's something that needs to be managed. As a result, the patients end up with the high post-void residual. They'll try to empty, and there'll be a lot of urine left behind. This can be a setup for urinary infection or bladder stones. So detrusor hyperreflexia is the most common urodynamic abnormality, occurring in up to 90% of MS patients. The patients with detrusor hyperreflexia, about a third of those will also have dyssynergia. Bladder areflexia occurs in about 20%, but some of these will then go on to progress to the hyperreflexia, the overactive bladder form. What can also happen with the bladder is that it should be very elastic. It's a muscle, and as a muscle, it should be able to expand and contract. And from the chronic damage from trying to empty and not functioning well, maybe infections, the bladder loses its compliance. Compliance is a term that we use where the change in pressure, the bladder shouldn't really change in pressure with the change in volume. In other words, the bladder should always be at a low pressure. But as it gets damaged and scarred, and scar tissue, fibrosis, replaces the muscle, you end up with this hardened bladder that is more like a hard ball than an elastic balloon. And then the bladder doesn't function well at all. It won't store, it won't empty, it just becomes rigid. So high post-void residuals, meaning that after the patient thinks that they've emptied, but it really has left urine behind, are associated with urinary tract infections and bladder stones. High intravesicular pressure, high bladder pressures, can have significant problems for the patient in that it can damage the upper tracts. In other words, the pressure gets transmitted up to the kidneys, and then the kidneys start to fail. Renal failure can be used to be much more a significant problem for the neurogenic bladder patient. It used to be much more common as a cause of death in the population with neurogenic bladder. Fortunately, we've become much more aware of it. We're much more active in preventing this from happening, so we don't see it as much as we used to. These t-shirts were tested on animals. They didn't fit. Now, one of the things that we will do in order to evaluate a neurogenic bladder, an MS patient with voiding problems, is we might do a test called urodynamics. And what urodynamics is, quite simply, is trying to reproduce in our office, in a laboratory setting, what is happening to them at home with their bladder function. And we create sort of an artificial environment where we fill the bladder with water, and then we ask the patient to empty while all these things are being monitored by the computer, and we're collecting data. So it's kind of interesting, I think, to understand what urodynamics is. There's multiple channels. There's usually these different channels, and this top channel is the pressure that's being read by the catheter that's in the bladder. The catheter has the ability to read pressure, and as the bladder is being filled with water, the pressures will go up, they'll spike. And you can see sometimes there are these rhythmic spikes. This is the bladder squeezing on its own. The patient is not not doing this. This is just happening spontaneously from the bladder muscle itself. We're also measuring the pressure inside the abdomen. A catheter is placed in the rectum, and that is the pressure that you create when you valsalva, or you bear down. So at this moment in time here, this patient was trying to urinate, bearing down, and creating pressure inside the abdomen. Now that pressure is going to get transmitted to the bladder, and our catheter will read that. So in order to find out what the true pressure is of the bladder, that's contributed only by the bladder and not by the abdominal pressure, the computer subtracts it, and this is really the pressure of the detrusor. This is the true bladder pressures that are going on. Okay, and again, you can see the bladder took a little jump here, uninitiated by the patient. It just did it on its own, and it did it here several times. And sometimes it'll follow this pattern, but it's the bladder contracting spontaneously. This down here is the EMG, which we place some pads by the patient's, by their anus actually. And what this is reading is the electrical activity of the muscles in the pelvic floor. And that's important for when we're trying to diagnose dyssynergia, because the sphincter should be quiet. Well, I guess that's the next slide. Okay, so this is dyssynergia. This is where the bladder and the sphincter are not working in coordination together. And you'll notice on the EMG tracing, there's increased activity here when the patient is trying to void, when the patient is trying to urinate. You shouldn't have that. The electrical activity of the muscle in the pelvic floor should quiet down. It should be less rather than more during the voiding, during the elimination. So, management of some of the urological problems. Okay, so our primary goals are to allow for adequate emptying of the bladder at a low pressure. That's our primary goal, is that we have to get rid of the urine waste with adequate emptying, but also at the low pressure, because if the patient is voiding at high pressures, they're liable to do damage to their kidneys. Of course, continence is important socially and for avoiding medical issues such as decubiti and skin breakdown, but that's actually second to the first goal. The third one is preservation of the upper tracts, as we talked about, and then being able to store and control the frequency so that the patient's quality of life is there. They can go when they need to go within a reasonable amount of time, that they have ample time between voids, and it's not interrupting their sleep, and it's allowing them to go out and be social and so on. So one of the first things we might try to do, the simplest thing we might do with a patient that has some voiding symptoms, is lifestyle changes. Fluid management. I had a patient in my office today. She was complaining of urinary frequency. And it took me a while, but after we started talking in detail, I realized this woman was drinking about 4 to 5 liters of water a day. Now, Normally, we would recommend drinking about 8 glasses of water a day. That's usually what is recommended, 8 glasses. Let's say a glass is about 250, so that's about 1.5 liters or so, or 2 liters a day. She was drinking more than twice that. Obviously, when you drink that much fluid, you're going to have urinary frequency. She was getting up 7 times at night. So one of the simplest things to do is to do a voiding diary and ask the patient to keep track of how much you drink and how much you put out, or not how much you put out, but how frequently you might go. And they keep a piece of paper for 3 days, and they monitor how much they're taking in and how frequently they're going. And if you bring that to your doctor's office, he can quickly tell you, is this reasonable? Are you drinking too much? Are you not drinking enough? Are you drinking too late? After dinner, you probably should reduce your fluid intake because it's much easier to urinate during the daytime when you're awake than to get up at night. So you'll still get your fluid intake during the day, but after dinner you should start slowing down so that you don't have to get out of bed so often. Caffeine is both a diuretic and a bladder stimulant. You'll make more urine as a result of caffeine, and you will actually go more frequently because it does stimulate the bladder. There are some foods that are bladder irritants, particularly alcohol, spicy, acidic foods, pickled foods. Not everybody's food sensitive, but if a patient finds that by eliminating this from their diet, they're going less frequently, it's a simple way to manage their frequency. Weight loss, that's good for everything. Bowel management. Many people don't realize there's a very, very close association between the bowel and the bladder. They live in the same neighborhood, so they affect each other. One of the reasons why patients can have urinary retention is when they have severe constipation. So it's very important to maintain the bowels. They're closely related. There's actually reflexes that go on between the bowel and the bladder. So you want to make sure that you maintain good bowel habits so that the bladder will function better. And then medications. Many medicines will have effects on the bladder. Many medicines have what we call anticholinergic effects. They cause dry mouth, they may cause constipation, but they can also cause urinary retention and voiding issues. So it's important to be aware of these medications and their side effects. So sometimes if we've tried lifestyle changes, we can then, another simple thing to try is behavioral intervention. There are some activities like bladder training, Kegel exercises, pelvic floor muscle training. Unfortunately, I find that some of this is not as effective as I'd like. We still will try it in patients that are willing to try. For example, Kegel exercises, which most of the women are familiar with, means having to tighten your pelvic muscles and hold it. And you got to do this several times a day. You got to do this about 10 times a day in 10 repetitions for 10 seconds each. And it becomes rather intrusive into patients' lifestyle to remember this. My recommendation is if you're reading and you turn a page, do your exercises, your pelvic floor exercises. If you're watching television, a commercial comes on, do your exercises. When you're in a car and you come to a stop, do your exercises so that the cues of living can remind you to do the exercises throughout the day. These exercises are not that hard to do. You could do them without anybody around you knowing that you're doing them. And you're just tightening the muscles and holding it for 10 seconds. If you're not quite sure which muscles I'm talking about, and it's very non-intuitive, these are not muscles that you're really familiar with. It's not the abdominal muscles, it's not the buttocks, it's not the thigh muscles, it's sort of the muscles in between. So if you're not familiar with what muscles I'm referring, while urinating, try to stop the stream. And if you stop the stream successfully, that feedback will tell you which muscles we're talking about, and then you can do the exercises when you're not urinating. It's not necessarily good to stop your urination in the middle all the time, but once you get the hang of which muscles we're referring to, then you could do those exercises throughout the day. So this is just sort of a repeat of everything that we've mentioned so far. So there are medications as well. Many of the medicines, you probably are familiar with them. The most common, the original medication for the bladder was, excuse me, oxybutynin or ditropan. It's been around enough years now that it's generic, and they have it available as a gel. You can even get it as a patch over the counter. You no longer need a prescription for Oxytrol, but I hear it's quite expensive. But anyway, what it is, it's a medication that calms the bladder down. And that was the original medication, and it's widely available. And it comes in an extended release form that is pretty good because it only lasts about 8 hours. But, well, I'm sorry? 4? 4 or 5 minutes till I'm done? Okay. Well, okay. Okay, here we go. Interstim. Interstim is a device that some of you may or may not be familiar with. It's a stimulator that is placed to stimulate the nerves. It works for both patients with urinary frequency urgency as well as patients that have urinary retention that's non-obstructive. We do it in 2 stages. The Interstim is done in the office under local anesthesia, and we find out if the patient's bladder will respond. You wear this device for about a week on your belt, and then you can go for the permanent implant. The permanent implant, the battery lasts about 5 to 7 years. I've used it in MS patients. I've had some that have had very good success and others that has been disappointing. Part of the reason why I think it's been disappointing is because you have to rely on the pelvic nerves to be carry the electrical stimulation, and if they're demyelinated, I suppose they don't work so well anyway. So it's been a little disappointing with Interstim. In patients that have overactive bladder or diffuse hyperreflexia that doesn't respond to conventional oral medication, we can inject Botox into the bladder. I was involved in the clinical research for using Botox for the overactive bladder, and it works quite well. It's a simple procedure. It can be done in the office under local, and Botox in the bladder lasts about 6 months. Now, the nice thing about Botox is you're putting the medicine in the target organ rather than having the patient take a pill that goes through her entire body and has side effects. Using the Botox in the bladder works without a lot of the other side effects, dry mouth and constipation, that you might get with the anticholinergic medications. Physical therapy is useful. They sometimes suggest using a medication for nighttime frequency, nocturia, called DDAVP or desmopressin. We use it in children who wet their beds. And basically, this is a hormone that slows down the production of urine. So it's really working on the kidneys, and it's not really helping the bladder at all, but you're just making less urine at night, and then you have to catch up during the day. It is not recommended for patients over 65. For males with incontinence and low voiding pressures, an external condom catheter simply collects the urine. And for patients that have severe problems with high pressures in their bladder, and we sometimes can, especially in spinal cord injured patients, will cut through their sphincter with a scope, and then they just continuously leak, but they have to wear a condom catheter to catch the urine. In patients that have bladder areflexia, patients that have sort of the floppy bladder syndrome, the bladder that doesn't contract, we can use alpha blockers to relieve the bladder outlet obstruction, to relieve some of the pressure when it's time to empty their bladder. Alpha blockers, most men are familiar with, is Flomax, or Rapaflow, or Uroxetrol, or Hytrin, or Cardura, doxazosin, terazosin. All of these were based on the blood pressure medicine that relaxes the bladder outlet and makes it easier for the bladder to get rid of the urine because the outlet is opened up. Intermittent catheterization, I'll talk about it in a moment. I mentioned Interstim, and in cases where nothing else is working well, we sometimes have to use a chronic indwelling catheter. Now, it's much better to put a catheter in through the bladder directly through the skin than to leave it in the urethra from below. The chronic pressure of having a catheter in the urethra will eventually wear down the urethra in both men and women, and they'll end up with an incompetent sphincter. And I've seen patients come in with openings to their bladder that you can basically see directly into their bladder through the opening in the meatus. So it's very simple to put a suprapubic tube in. It's easier to manage for the patient. It has to still be changed once a month. And it's very functional, although it's sort of the last resort. So this is just to give you an idea of what it's like for patients to do self-intermittent catheterization. The catheter is just passed up into the bladder, drain the bladder, and that can be done intermittently throughout the day for patients that don't have the ability to empty their bladder themselves. They have these small catheters for females. It's the size of a lipstick, and it's very compact. It's easy for them to carry and use, and eventually it's sort of like brushing your teeth. It gets to be very simple to do the self-intermittent catheterization. It's not very complicated. You don't have to have a lot of equipment or supplies, and patients don't get infections, really. That's always a concern. They really don't get very much in the way of infection, and it's not a very complicated or difficult process to learn. You do have to have reasonably good hand function, though. Other related issues are recurrent urinary tract infection in the MS patient due to their immunosuppression. One of the easiest ways I find to avoid infection in patients that are prone towards urinary infection is to use a combination of vitamin C, cranberry capsules, and a probiotic. You want to take excess vitamin C. Vitamin C is ascorbic acid. And so you take 1,000 milligrams at least twice a day. What it does is it acidifies the urine. It's a water-soluble vitamin, so it passes through your system very quickly, and it makes the urine acidic, and the bacteria don't like acid urine. But you have to dose yourself several times a day. And you want the cheap vitamin C, because the good vitamin C is designed to stay in your body. We don't want it in you. We want it to pass through into the urine. So you take 1,000 milligrams of the really inexpensive vitamin C a few times a day. Okay, I got to speed it up. Okay, cranberry capsules. Cranberry has been shown to avoid infections, but the capsules work better than the juice. So you want to take cranberry capsules along with the vitamin C twice a day. Probiotics, especially in females, you want the lactobacillus probiotic. That is the one that lives in the vagina. It's the good bacteria that makes lactic acid. And the bacteria it lowers the pH in the vagina, prevents recurrent infection from acidifying the vagina. All right, good. So you caught all that, right? You read those as I sipped through those. So at this point, I'm going to see if anybody has any questions, because I always think that's kind of, or do you want to?
So what we're going to do is we're going to do Q&A for both of you.
Oh, very good. Okay, great. Thank you very much for your attention.
Thank you for your time and for coming to educate us. That's actually what we wanted, right? So let's do some questions. First off, for anybody that does not want to just like jump up, raise their hand, and speak orally, we'll take your question on a card. So if anybody needs to do that, please raise your hand. Carmen's going to go around the room with a microphone, and she's going to see whoever raises their hand. She's going to run back and forth all over the place. So that way you could ask questions. Thank you. And then our speakers, if we can have you repeat the questions. Okay? So whether it be for urology or neurology, you have a question, she's in the back right now, you have to wait. Whether it's neurology, urology, raise your hand, you want to ask a question, please do. Wait your turn, whatever. You'll see Carmen come around the room, flag her down, grab her by the legs, whatever.
I have a question. Has any of you doctors heard about soursop extract for multiple sclerosis? I read something on the internet. Of course, you can't always read what you hear on the internet, but I understand they've been doing some studies about possible cures for MS, and they mentioned the fruit that comes from the soursop, S-O-U-R-S-O-P. Thank you.
I mean, no. The answer is no. I've never heard of that. But on the internet, you know, every day you'll find something new, some new remedy, some new fruit, some new vegetable, some new herbal product, something new that somebody's selling. But that particular one I've not heard of, not yet.
Yeah, I have a question. When Dr. Steingo, you said it attacks and MS episodes. Can you describe a little bit more in detail what an attack and an MS episode actually is for more people than not?
Yeah, so we said MS at the beginning is primarily an inflammatory disease. So an attack means an episode of inflammation. And the reason I gave all those different words is because different people call it different things. Some people call it an attack, some people call it an episode, some people call it a relapse. You could call it an exacerbation. You could call it any of those things. Some people call it an exasperation. That's the name they give to it. And I said it is exasperating, but it isn't really that. It's an exacerbation. But it means that you're having an acute period of inflammation. So like I showed you that one slide with all those millions of white blood cells around the vein, when someone is having a relapse, that's what's happening in the brain or the spinal cord. There is an attack of the immune system on the brain, and there are white blood cells actually attacking some of the brain tissue and causing a loss of myelin and damage to the myelin, and eventually even maybe damage to the nerve. So that's really what's actually happening in a relapse. The definition of a relapse is a strict definition. A relapse is an event that must last at least 24 hours. If you have 15 minutes of numbness or blurry vision, we don't consider that a relapse. In order for something to be considered a relapse, it has to be an event that lasts at least 24 hours. It can be something completely new or something you had before that got worse but lasted at least 24 hours. So that's our definition of relapse. And there should be nothing else causing the symptoms. For example, you might have a fever from an upper respiratory infection or urinary tract infection, and you might feel worse that day. That is not a true relapse, because once the infection is treated, you might get better. So you might not be having a true relapse. On the other hand, you might be over the infection and your symptoms continue to get worse, and that means the infection has triggered a true relapse.
Sure. My question is, Dr. Steingo, earlier you talked about a relapse may cause an increase in your disability, in your disability scale. Can a pseudo exacerbation also cause a permanent spike in that?
No. Well, if it's a pseudo relapse, that means it was just a temporary thing. So, for example, someone has difficulty walking, they have a relapse and they're bedridden for a few days, their temperature is 104, and they're totally bedridden. 104 is going to make anybody feel weak, so if you're weak to begin with, it's likely you may be bedridden, and then once the fever goes down, once the infection is treated, you'll get better. That would be a pseudo relapse. If the infection goes, the temperature's down, the infection is treated, and someone is still very weak, lasting, extending, then they may have had a true relapse. Then we would consider treating that kind of relapse. So pseudo relapse is a temporary thing. A true relapse will have ongoing symptoms. I guess, do we have a microphone, or how are we doing this? We have a card. I can answer. Let's see.
Hello? Hello.
Hello. Okay.
I have a question. Our daughter has MS, and she's had it for 2 years. And she was on high doses of steroids, okay? So consequently, she has the weight gain. And I just don't understand, because every time she goes, every month she gets to Sabre. And she's not lost a pound, and she's trying so hard, and she's watching her diet and eating low-fat foods, but she's not losing anything. Why, and what would you recommend that she can start to lose some weight?
I think if I had the answer to that, I wouldn't be here, probably. I'd be in one of my 25 condos if I could tell you how to do weight loss. But this is a fact of steroids. Steroid does cause retention of fluid, firstly. So people that take a course of steroid or Solumadrol gain some weight from the fluid, they often lose that. But steroid can do other things, other metabolic things in the body. It can cause increased appetite. So people that have steroids usually may gain some weight. Now, if you have steroid just one time, it's unusual for people with MS to require steroid after dose of steroid after dose of steroid. In fact, most people don't use that. It's not really a recommended therapy to do dose after dose after dose. If someone is not responding to their drug, you need to change their drug. And if steroid is not working, we have to find some other way to treat the relapse. But once you've gained the weight, once someone has gained weight, 25 pounds or 50 pounds or whatever it is, it's the same. You have to go to see you have to see a weight loss expert, somebody who knows how to lose the weight. And whether it's a combination of changing your diet and changing your intake and burning up more calories and doing some exercise, it's a combination of all those things. It's nothing peculiar to MS at all. It's just a general, how do you lose weight? Go and see somebody who's an expert in that field. Maybe see an endocrinologist. Make sure there's no other cause of weight loss. Do you have underactive thyroid? Is there a thyroid problem? Is there something else that's causing the weight loss? So somebody like that needs to see an endocrinologist maybe, and then if there's no hormonal cause, then go and see a weight loss expert.
Yeah, she's really done just about everything, and I don't know. The other question I have is that she also gets twitching, like here on your arm and then on your leg, and that's just kind of started. Is that something she's going to have to just live with for the rest of her life?
I mean, it depends how bad. There are medications for twitching. If the twitching is a nuisance, you leave it alone. Like I say, you're already taking a bunch of medications, and there's potential for 100 different medications. So if a symptom is a nuisance and you can live with it, you just wait and see what happens. If the twitching is causing a problem, then there are medications for it.
All right, thank you.
You're welcome.
With depression and MS, is it caused by lifestyle changes, or is it actually something in the disease change of chemistry?
All of the above. So what they've done is they've studied depression MS, and they said that depression MS is more common than in other chronic diseases. So people with rheumatoid arthritis could be severely disabled, or people with lupus. Lupus is a potentially fatal disease. Actually, the outcomes are much worse than MS. Or Lou Gehrig's disease. People die in 5 years, oftentimes. And yet, with all those chronic diseases, MS patients have a higher risk of depression. So it is something intrinsic to MS. In addition to that, what you said was correct. It's sometimes a change in the life, and now you've got to face a whole life, potentially, of being disabled. So it's a combination of factors.
Yeah, hi, my question is on the urology. I don't remember I don't remember a lot of things, but I don't remember that you mentioned the sphincter spasm. Seems to be a problem that, with my particular bladder issue, I have a difficult time with that.
So when you say sphincter spasm, you're talking when you need to urinate, it doesn't come out easily. Correct. Okay, that's dyssynergia. That's what I was referring to when I was saying that the bladder outlet, including the sphincter, the pelvic floor muscles, may not relax when they're supposed to, when it's time to eliminate. So the easiest thing to use for those patients, to start off at least, is something like alpha blockers, Flomax and Uroxetrol and Rapaflo. They work to some degree, not completely, but they do work to some degree.
Sometimes the intermittent catheterization, the sphincter is fighting the catheter.
Yeah. What he was saying is sometimes with intermittent catheterization, he can feel the sphincter fight the catheter. There is a reflex. I mean, it happens in normal patients too. When you get close to the urethra, the initial reflex is for it to close down. If you wait a second or two, it doesn't take long, it'll relax a little bit, and then you can advance the catheter. But when you get to that point, that's usually the tightest point in the system in self-catheterization, is right at the external urethral sphincter, the bulbar urethra. You relax, you try to relax as best you can, give it a second, the muscle should relax and allow for the catheter to go in. It's also where the S curve is. It's right at that point where, so it's a tight area. One of the cards I have is for a question regarding the bowel program, trouble going to the bathroom. There's no specific bowel program except in patients who are really chronically constipated and have really a neurogenic bowel. Then the easiest bowel program is to use a Dulcolax suppository. We expect patients to have a bowel movement probably about every other day. It doesn't have to be every single day that you have a bowel movement, but at least every other day. So in order for these patients who are chronically constipated to avoid having an accident at an undue time, you can use a Dulcolax suppository, and if that's placed within about a half hour, that should stimulate a bowel movement. So you can time when you're going to have the bowel movement, is using a Dulcolax suppository. But otherwise, if it's just chronic constipation, you go to the pharmacy and there's an entire aisle dedicated to that one problem. And everybody's different. Everybody can figure out what works best for them. Either it's dietary changes or it's something that's over the counter.
Dr. Samowicz, can you say with any certainty that a urinary problem is attributable to MS?
No, that's a very good question. Can all urinary problems be attributable to MS? Because urinary problems are so prevalent in the general population, that overactive bladder and prostate issues are so common amongst the general population anyway, sometimes we have to dissect out how much of it is related to the MS and how much is just another common problem that we find in the general population. So it sometimes gets complicated because multiple factors are playing a role.
This question is for Dr. Samowicz. It actually kind of goes with that, but when I was 12, I actually used to take medicine because I had a really overactive bladder, and they said I had a weak bladder. 10 years later, when I was 22, I was diagnosed with MS. Could I know obviously you said it doesn't necessarily have to be, but is that possible to be like that young in your preteens, that could be a symptom that early?
Well, I'm going to probably ask Dr. Steingo that question because that's not, there are young girls that will have voiding dysfunction at a very young age, and they don't go on to progress to MS. They don't go on to progress to other neurological issues. Some of it can be, it can be complicated, but some of it can be sort of self-induced, that they don't really learn how to, they have to be taught how to void properly, when to relax their pelvis and when to tighten. And then they can go on later on in life and have voiding issues. And some of these patients respond very well to physical therapy. I send them to a physical therapist who sort of retrains them and teaches them how to empty their bladders more appropriately.
It was actually like excessive frequency. Like I was getting in trouble when I was in 12th. I mean, when I was 12.
Right.
For class, so it was like a lot.
And maybe incontinence or nighttime incontinence, waiting the bed or things like that?
No, it wasn't that. It was literally during school.
You know, the bladder, again, is a complicated organ. It could be for various reasons. Anxiety can provoke it, and there could be other issues.
Okay.
But it's hard to say it's connected with MS. I wouldn't make that.
I just didn't know if 10 years before that could be like an early symptom. I was just curious.
We see enough young girls with voiding issues that don't go on to progress to MS that I think is probably separate.
Okay, thank you.
Should we do some of these cards?
Sure.
Want me to do some? I'm just, let's do some of these cards. They might answer questions that anybody has. And the one here is, why are MS symptoms different in different people? And you know that looking around, that MS can be a very different disease. I mentioned to you before about the so-called benign MS. About 5 or 10% of people have benign MS. 5% of people might even have what we call malignant MS. And then most people fall within the middle range. And we think that MS is probably different in different people. It's probably more than one disease that at the end of the day causes the symptoms. Because some people respond very well to medication, some don't respond. Some respond to one medication, some respond to another medication. So with time, as time goes by, we're probably going to find that MS represents more than one disease. That there's probably several different things that cause the same end process, but there may be several different things causing it. That's why MS is different in different people.
And different within the same patient over time.
Yeah, it can change in the same patient from relapsing to progressive. Does MS ever go away with age? The answer is yes and no. And what I mean by that is that MS can burn out. All autoimmune diseases can burn out. That means the disease just stops becoming active. But does it go away? No, it doesn't go away. The disease has caused scars in the brain and the spinal cord, so the damage, unfortunately, does not go away. So the effects of the MS may be permanent up to that point in time, but going forward, there may be no further activity of the MS. It can burn out, and there's no progression of the disease or no relapses after that. That could happen. And if someone is completely stable, there's several questions here about the MRI scan. And the answer to the MRI issue is that we do MRIs early on more frequently. So early on, we want to know when we're treating you, how are you doing? Is your scan showing good changes? Or is there no progression on the scan, no active disease? So early on, we might do more frequent MRIs. Once you've been on treatment for a while and you're stable, we'll do MRIs less and less frequently unless there's an active event. So that would be the answer to the MRI thing. And sometimes we're restricted by the insurance companies. We might want to do scans, but the insurance company might say you can only do so many scans. There's a question here about disability level 4. I told you about disability. Our disability scale goes from 0 to 10. The highlights are a 6.5. A 6.5 is using a walker. A 6 is using a cane. A 5 is walking independently. When you go from a 4 to a 5, a 4 is somebody who could walk. They could walk about 500 feet. They can't walk beyond 500 feet. When you start walking less than 500 feet, then you start moving up. So a 4 could be someone who's just at the beginning of really noticeable walking problems. That's where you would see that 4 cutoff. The question here about what drugs are most effective for progressive MS. So for progressive MS, our emphasis is on treating the symptoms. Unfortunately, there is only one approved drug for secondary progressive MS. It's called Raton. It is a toxic chemotherapy drug that nobody uses anymore. It's too toxic. And for primary progressive MS, there is still even now no FDA approved drug. There are some drugs in clinical trials. We won't know the results. These are very long clinical trials. A clinical trial for progressive MS usually lasts about 5 years. So these drugs are still in trials. We're hoping that some of them come out positive. But the last time we thought a drug was going to come out positive was Rituxan, and it failed to meet its end point. It did not show benefit. There was a clinical trial done with Copaxone in primary progressive MS that failed as well. So drugs that have been tried so far, unfortunately, have not been successful. The last card I have here is I talked about tetracyclines. Tetracycline or minocycline are antibiotics. They're commonly used for infections, kidney infections, upper respiratory infections, acne, and things like that. Yes, that's exactly the same drug that they've been trying in MS because it has other effects on the immune system, and they're trying to see if maybe these could have some effect on the disease. Certainly be a lot cheaper than anything we have available right now. And the final question is about optic atrophy, and so I talked about that before. The optic nerve is a nerve that has millions of nerve fibers, and if some of them are damaged, if the actual nerve fiber itself is damaged, then it does not recover, and that's what leads to atrophy or shrinkage of the nerve. And it can happen. The same thing can happen in the brain. People with MS, if you look at their brains, have atrophy, and their brain scan as well, more advanced than their peers of the same age. That's the result of the damage in the optic nerve.
Question here with the microphone.
Hi, Dr. Steingo.
Hello.
I just have a question. I've been on Tysabri for about 5.5 years now, and I am not allowed to have steroids. And I was just concerned about the woman who spoke earlier about her daughter who was on steroids and Tysabri. I didn't think that was possible because every month that I go, they ask me if I've been on steroids.
So the answer to your question is you can have steroids and Tysabri, just if you have a relapse. If you're on Tysabri like any other drug and you have a relapse, we would treat that episode, that exacerbation with steroids, and we might delay that next Tysabri treatment for a couple of weeks. That's why we ask you the question every time. But if you are needing steroids on a regular basis, that means the Tysabri is not working for you. That's why it makes no sense to be on a regular basis. But if you have a relapse on Tysabri and it's one relapse, then we do two things. Number one, we might treat you with steroid. Number two, we'd say, is your Tysabri working for you? If you're having a relapse, maybe it's time to reevaluate and be thinking of other medications. But once in a while, if there's a relapse and it's a mild relapse and the drug is working in general, we might do that. But if you're having a lot of relapses, it means that the drug's not working. Okay?
Thank you.
You're welcome.
I had a question about the medicine that is not approved, FDA approved, Lemtrada, the once-a-year IV infusion or whatever. Did something recently happen?
Well, it's, the company has presented to the FDA recently, and the FDA said on the 27th of December, in 3 weeks or so, they're going to announce whether they approve it or not. And so the FDA has criticized some things about the study, and there's a big movement amongst people that treat MS to write to the FDA and tell them that this decision should not be your decision, because you guys have no clue. Most of the people on this panel were not actually even MS neurologists. They knew nothing about MS, and they criticized the study in some ways. And we're saying to them, let the people that have MS and let the doctors decide whether people should take this. It is a highly effective drug, but it has a lot of side effects. But if we know about them, we can watch for them, and so we're saying let us make the decision, not you. The 27th of December is their date.
I have cerebellum atrophy, and my doctor was Walter Bradley at Miami Jackson. He retired. When I last saw him, there was no medication at all. So I'm curious, has that changed? Is there anything I can take now?
Are you saying anything you can take for cerebellar atrophy?
Yeah.
No, not specifically. We have no medication that restores atrophy. This is going forward research for the future, hopefully stem cell research. But for right now, there's no specific medication to restore cerebellar atrophy.
Because I do a lot with diet and exercise, so I'm in very good shape.
Yeah, that's good. That's very important to maintain.
Very important. I do a lot.
Absolutely, very important.
So my progression has been very slow.
Good. Okay. Yep. Eating healthy, exercise, very important.
We're going to have just 2 more questions from the audience, and then Dr. Samowicz has, you go first. You go first with a couple of questions you have, and then we'll do the 2 from out here, and then we're going to have to wrap things up.
Okay. Why does bladder incontinence frequency happen more at nights for some people? Nighttime frequency, nocturia, can be very complicated. It can be related to multiple factors. Some people literally make more urine at night. It has to do with some hormones, but also during the day as we're standing, gravity will pull some fluid down to the lower part of our body, and when we finally lie down, you put your legs up, that fluid then shifts back into the body, and you literally will make more urine at night. So it's multifactorial why some people will make more urine at night. Does drinking decaf or green tea beneficial to eliminate problems related to caffeine intake? I don't know. I think, caffeine is a problem, but sometimes it's just a fluid. And if you're drinking a lot of tea, that can be an issue. The other question on the back is, what probiotic do I recommend? Again, I don't have any specific names of probiotics, but if you're taking a probiotic more for urinary infection rather than for the bowel is usually acidophilus. For the vagina and for avoiding urinary infection, it's usually more lactobacillus. I think some of these other questions I already answered, so I'll let the audience answer.
Okay, we have
questions.
a question right here first, please. Oh, he did. Okay. All right. One up front left, one up front right.
Dr. Samowicz, in addition to the probiotic, you also suggested vitamin C in 2,000 units a day. Is that contraindicated for MS? Dr. Steingo, you have previously said things about vitamin C. Is that okay to use 2,000 units?
Yeah, what I said is that I think you shouldn't take vitamins in excess, especially the vitamins you can measure. But vitamin C is okay to take. Yeah, vitamin C is fine.
There's some vitamins are water soluble, some are fat soluble. So A, D, E, and K are fat soluble. Vitamin C is in the water soluble group. Therefore, it passes through you very quickly. Linus Pauling wrote a book called The Vitamin C Solution, in which he recommended people taking 10,000 milligrams of vitamin C daily. Now, he didn't have MS, but he lived to 93, and he won 2 Nobel Prizes. So he wasn't a stupid guy.
Okay, before we take the last question up here, I want to let you all know something. If you have any questions that have not gotten answered tonight, you can send an email to me. I will pass it to the correct doctor. Then we will get the response and we'll send it back to you as well. Okay, so you could do that by email, or if you want, just drop it off to me on your way out of here. Also, please remember those seminar evaluations, and after this person asks her question and it gets answered, we'll do the raffle. But before that, we're going to want to pick up the seminar evaluations as well. Thank you.
Can any urologist give you a Botox shot, or does it require special training?
The question has to do with Botox. I started using Botox about 8 years ago, and the only way that I could get it for my patients back then is to be a clinical researcher. So I did the research studies several years ago. It's now FDA approved. Any urologist theoretically can do it. It's not hard to do, truthfully. You can read about it and just do it. It's not a complicated thing. But it's not so much the procedure that's important, it's knowing how much to use, when it's appropriate, that sort of thing I think is more difficult to teach somebody.
Okay, so thank you again, doctors. I'd like to personally thank both of them for helping out with many of the programs that we do, and we'll continue to use and ask them to speak at our programs in the future. Thank you. All right, so where are these raffle tickets? All right, so, we always try to do this because we always want to give something back to the MS community. So MS Views and News likes to offer a raffle or two. And since, this is a great time of year for people who want to watch videos, we decided we'll go with a Blu-ray disc player for this evening. And so that way you see that I'm actually mixing them up, right? Anybody want to say when to pull? That's good. 8, 8, 4. By the way, you turn in your seminar evaluations? 4, 2. Any more questions? 9. Okay. Thank you, everybody, for helping us make 2013 a very, very great educational year to provide information and education. And we hope that you tell others to register at the MS Views and News website, look at our YouTube channel, see the information we have on Facebook, Twitter, and everywhere else, and have a very happy holiday season and a great new year.